Test him 1.
Test him 2.
Test him 3.
Yeah.
Perfect.
With the question. That's it. That's it. Well done. Welcome, everybody. Welcome to the Testing Podcast, and welcome Professor Amr Raheem, consultant Uro-Andrologist. Did I get that right?
Yes.
Brilliant. No, thank you so much for coming to join us.
Thank you. It's a great pleasure to be with you.
Yeah, looking forward to this conversation. We've already had like a whole podcast conversation off camera, haven't we, before we even hit record?
I know, we've got to save the good stuff for the actual podcast. I said we better hit record because we've got some good conversations.
A number of times we do that when we've got guests. It's like all this great conversation happens before we hit record. Like, oh, no, wait, we've got to...
And then we end the podcast and go, bloody hell, we didn't talk about this.
So we've got a lot to cover. We've got to say, we're sorry that Mike's not here today.
Well, that feels weird about Mike, doesn't it?
It does feel really weird.
Testing 4 for Mike.
Yeah, testing 4 for Mike. He's a bit held up, but we'll do the best we can with that.
Next time.
Next time.
Yeah.
Yeah, next time. Yeah. We're happy to have you back in, I'm sure. So, Amr, tell us a little bit about, because I could sort of try and read a bio about you and say this, that, and the other, but you're the best man to tell us about you. So, tell us a little bit about who you are and your kind of history and how you kind of got into the space.
So I'm specialized in men's health. So men's health or Uro-Andrology is a subspeciality or a niche speciality that deals with all aspects of men's health, medical, surgical, hormonal, and even psychosexual. So I trained at the andrology department at Cairo University Hospital, where men's health is an independent speciality.
Oh, really?
So I've been doing this for 25 years now.
Oh, you don't look
old enough. So we have a dedicated department just dedicated to men's health. And then I came here to London. I worked at University College London Hospital, where also men's health is autonomous, part of the urology department, but there's an independent andrology unit. And so I've done a number of clinical trials, publications, research, in addition to clinical practice, seeing patients, operating. And I enjoy what I do. So.
Yeah.
Sounds very busy, doesn't it? It does sound very busy. 25 years of being in the field. So what got you into it? What got you interested in working in this field?
Well, again, because when I was an undergraduate, we had because it's men's health is a unit on its own, so we had an andrology round, and then I found the subject interesting in the sense you've got medicine, you've got hormones, you've got psychology, you've got very fine surgery, reconstructive surgery, plastic surgery, microsurgery, and also that it was a relatively new speciality. So that means you have room to be sort of, you have room to innovate, you have room to do to be an innovator. In that field. So, and that combination of medicine, surgery, hormones, and psychology, I found that interesting.
Yeah. Actually, we should warn all listeners now that we may end up talking about penile implants and penis surgery and goodness knows what else on this episode. So if you're eating your dinner,
I only operate on penises and testes, so this is what I...
Yeah, just if someone's having their dinner. If it's meatballs or sausage and mash tonight.
Sausage and mash.
Blimey. And kind of how much has kind of fertility been part of your kind of history in terms of your workload and kind of your focus?
Oh yeah, fertility is a big component of my work, and my master's degree and my PhD were actually about ejaculatory duct obstruction, which is a very underdiagnosed type of obstructive azoospermia. So it's a good part of my work.
I've never heard of that in all these years.
Yeah, well, please explain what that is, because just for our listeners.
Well, it's a type of blockage. You know, azoospermia, it can be non-obstructive or obstructive. So 1% of men are azoospermic, so that means no sperm in the ejaculate. 60% is non-obstructive. That means it's a functional problem in the testes. And 40% are obstructive. So we can say that 0.4% of men have obstructive azoospermia. So the blockage can be inside the testes, at the tail of the epididymis, at the level of the vase, or at the level of the ejaculatory duct, which runs in the prostate. So when the blockage is at the level of the ejaculatory duct within the prostate, this is called ejaculatory duct obstruction, or EDO. This is a surgically treatable cause of obstructive azoospermia. And I'll tell you guys a little tip. So when you're doing a semen analysis, if you see low semen volume, acid pH, azoospermia, negative fructose, this is pathognomonic of either ejaculatory duct obstruction or congenital bilateral absence of the vase, which is another cause of obstructive azoospermia. So the semen analysis, in that case, you then do a semen analysis. In that case, you just do a transrectal ultrasound and, of course, examine the patient clinically to check for signs of, to see if the vas is present or no, and signs of obstruction.
This has got very technical very quickly.
Yeah.
Where's Mike?
But I hope it's simple. You know, I'm not trying to
Yeah.
make it complex.
But this is where actually the importance of a semen analysis and being able to read it and understand it is really, really important.
I think, you see, the thing with men's health is, or with fertility, that's based on my experience, and I work in different countries, is that the whole fertility is mainly dominated by IVF. And as long as there is sperm in the ejaculate, those men, I'm not going to say in all cases, but in many cases, they don't get assessed or investigated properly. And sometimes the aim is just to retrieve sperm without trying to understand what is wrong. And, or if that is something that can be treated or no. So the aim is just to get sperm for the IVF. And I think this is a problem. So semen analysis is one of the things that are important, but there are other things, like you need to know when you ask for a hormonal profile, when you ask for a genetic screen, imaging like scrotal ultrasound, doing a semen culture, although of course this is debatable. But so there are so many things, sperm DNA fragmentation. So it's like any medical condition. When you're managing, you need to take history, you need to examine the patient, you need to run a battery of investigations that depend on the case. So, for example, if I see a patient, low semen volume, acid pH, azoospermia, negative fructose, I'm going to order a transrectal ultrasound as a part of my examination. If I don't feel the vas, I'm going to order a KUB ultrasound because he might be missing a kidney. I'm going to ask for cystic fibrosis screen for him and his partner because some of the types of obstructive azoospermia, especially vasal aplasia, are a mild form of cystic fibrosis disease. So let's say you got sperm from that person and you didn't screen his partner for cystic fibrosis, they can end up having a baby with the full-blown picture of cystic fibrosis disease.
Really important point, that.
Management is like any condition. It's not one test, it's not one symptom, it's not one sign. It is... And that's the whole thing. Like male infertility is a type is a sign that that something is wrong. It may be genetic, it may be hormonal, it may be cancer, it may be a blockage, it may be trauma, it may be infection. So it's like managing any other health condition. And the aim, of course, of why we do this, I mean, our aim is help every man father their own child, which is, you know, yes, of course, donor sperm is available, but as a guy, you want to have your own, you want to father your own. And the second thing is to improve the outcome of IVF. So I'm pro IVF, but you want to make it succeed. You want to raise the success rate of IVF by improving the male fertility. So even if we're going to do IVF, there are things that we can do to improve the outcome of the IVF. And of course, most importantly, you want to know what's wrong with that man, even if you're not going to be able to treat it. As a patient, you want to know, why is my sperm so low?
Sure.
Is it something that I have done, that I had done? Is it something wrong? Is it that, so you want, and of course, some of the problems can be hormonal. It's like, I'm not trying to scare people, but testis cancer is much more common in the infertile male population compared to the male population. So it's estimated to occur in 0.5% of the infertile male population. Right. And that's why when I see any patient with low sperm count, as a part of my examination, I do a routine scrotal ultrasound. I do it myself in clinic. It takes 5 minutes, but just to make sure that we don't have there are no suspicious lesions within the testes. So
it's that point, isn't it, of that male infertility or male subfertility is that biomarker for so many other things, and we're doing a huge disservice by just pushing these men towards IVF. Like I say, IVF's definitely got its place, ICSI's got its place, but by just saying, oh, you've suboptimal fertility, your semen analysis is a bit duff, just go for IVF, we're potentially missing all of this other stuff.
So the thing is, you can treat some, even if they're going to have to have, even if they will have to have IVF, which again, we're pro whatever works. We need to know, we need to make sure that there are no underlying risk factors. We need to improve the fertility, if possible, with the hope that they conceive naturally, which is more cost effective. And even if they're going to have IVF, the couple, we will improve the outcome of the IVF.
The health of that child.
And of course, the most important thing in the decision, or even the success rate, not necessarily the health of the child, but the success rate of IVF. So, for example, if I have a patient with with high sperm DNA fragmentation, that means that the IVF is going to have a low success rate. If I treat the high DNA fragmentation, I'm improving the success rate. Okay, so it's the success rate of the IVF and ICSI cycles in general. Of course, it's something very important: the age of the female partner. So so if for example, the age of the female partner and the ovarian reserve, because time is of essence. So management is multifactorial. So it depends on what the couple want, the age of the female partner, what her gynecologist thinks about her ovarian reserve. So it needs to be teamwork as opposed to us working in isolation. And I realized this when I was doing the male fertility clinic at University College London Hospitals, and I sat with the lead gynecologist, and I suggested that the service is very disorganized, so they may see a couple. There's a strong male factor. They refer the patient to the urology department. By the time the patient gets seen, it could be 6 months. Then we ask for a test, and then it takes ages for that test to come back. So there's complete dissociation in the service. So I suggested that we do a joint clinic where we have a Uro-Andrologist and a gynecologist and even an embryologist, and we see the couple together. So that has helped streamline the service and improve the outcomes significantly, and it's still running till this day.
Which is a great way forward, isn't it?
Absolutely.
Yeah, I think I just want to go one step further as well. Obviously, you mentioned about kind of improving the ingredients. I'll try and put it into layman's terms, but yes, of course, if we can help increase the success rates of IVF by helping look at the man themselves, but from my own experience, having gone through fertility issues, our dream as a husband and wife was to always have a child naturally, if that was possible. And quite often, if we can look at having a proper diagnosis of the man, you're also increasing those chances as well of a natural conception.
Exactly.
Which let's face it, is kind of the ultimate goal. And it is very possible. I remember when I did my semen sample for our first IVF cycle, That was traumatizing. You know, I'm sat in a room with a pot with a picture of my face on it. I've got to fill it up, and that's as romantic as it was to create a baby. You know, it wasn't.
Your face is enough to put anyone off.
I know, exactly. I've put myself off plenty of times, but yeah, you know, and that was horrible. I remember feeling really emotional and teary, and you know, it's a difficult process to go through. You know, we went through a male factor diagnosis myself, which led for us to have a natural spontaneous pregnancy, and actually, when we look back at all that, we have that kind of shared memory together, which I think is quite important if that is achievable. So the work that you're doing is, yes, of course, we're looking at the complete picture here, but if we can help people have babies naturally as well, which this obviously does, there's a lot to say for that, because you haven't got to then go through the psychology of going through, you know, an IVF cycle necessarily. But
it's still a relatively unique offering, isn't it? So what you created at UCL, that kind of combined clinic, especially with an embryologist, I think that's really great to have their input, because they're the ones that see it all in the lab.
Exactly, it's teamwork. So
yeah. That would have been quite unique at its time. How long ago did you set that up?
Oh, that was back in 2012.
Right, yeah, so 14 years ago.
Yeah. I think it's still running. I'm not there there anymore, but I think it's still running.
But we've had Jazz Kelsey and Fatima Hussein in here, and they've done the same. They've set up a joint clinic, and it was just music to our ears, wasn't it?
Mine was the first.
Yeah. yeah. But that's still unique.
Yeah.
It's like, why is it like 12, 14 years ago you've set that up?
Because I saw the way the service is disorganized.
But why hasn't that now, you know, spread into the industry a bit more?
I think now it's very I think it's the idea is spread now, and many units are doing it.
Perhaps more are doing it, but it's not.
At least on within NHS big fertility units, I think, because we were doing it at the EGA wing, which is the women's health department at UCLH, and I think that model has been replicated.
That's good to hear.
I think it needs to happen earlier, though, because I remember when we were going through kind of our NHS funding, we went from our GP to a gynecology-led fertility. I want to call it a treatment assessment centre, and it wasn't a clinic to actually treat us. It was just to sort of see if we were fit to have IVF, and that was led by a gynecologist. I didn't have any, other than semen analysis, any physical examinations, etc. I certainly didn't have a DNA frag. And of course, during that time, I did have my varicocele, because it was very much there. And that was really kind of a screening process to allow us to get funds to go to IVF. And then we went from that straight into IVF clinic, a private IVF clinic funded by our NHS rounds. So, you know, I think if we can bring that back, that this becomes a standard at that phase, for me, would have made a complete difference to our whole outcome.
Would have saved funds as well.
Correct.
NHS funds, because you had I think also it's because of the number of urologists with special interest in men's health. Maybe it is the gynecologists. The numbers are larger, so you don't have enough. But I think now we've got centres of excellence here in the UK, like University College London Hospital, Guy's and St Thomas, and there are people that are being trained up. So I think that will significantly improve the situation, because I think there was, back in 2012, there was fewer urologists specializing in men's health, but now there are more numbers.
We've got to make it trendy for the
for the youngsters.
New, for the new breed.
Yes, we need to make it trendy for the youngsters. How do we do that? So you've been in this industry 25 years. You were clearly excited and interested in men's health, and there are, we meet a lot of urologists out at conferences, and a lot of them seem to be in the penile cancer, testicular cancer kind of realm, penile implants. They're kind of doing that side of urology, but they're not so excited about the male fertility side, which for me and us seems crazy, because it's like, surely there's nothing more exciting than helping a man have his own biological child. So why is that, and how do we change that, do you think?
Well, I think is if we make if we raise awareness that if you are subfertile or infertile, you need to be screened, assessed, evaluated by a specialist. That's going to create demand for the service, and that will encourage more doctors to offer that service.
Yeah.
It's like anything, because if there's
Supply
a
and
demand
demand.
for if there's a demand for a service, people are going to meet that demand. So
Yeah.
I think that's it's all about raising awareness, and the patients request that actually, can I see a specialist with male infertility, or can I see a urologist who does male infertility? I want to be evaluated by a male fertility specialist. That's going to create the demand and interest. But again, the aim is, I want to emphasize or put stress on this. It's teamwork, so it's a team. We're not, it's a team. The end game, the aim of that teamwork is to help the couple conceive, whether naturally or via IVF. So it needs to be teamwork between the Uro-Andrologist, the gynecologist, the embryologist. So it's not about, who should do what or what is better. I think it's about what works. And we had that discussion about, do we do surgery or embolization for the varicocele? Again, it's what works, But the important thing is to actually manage.
It's what's appropriate, isn't it? And like you said, you've got to take that history. You've got to look at the female side as well, like I said, age, ovarian reserve, PCOS, endometriosis, whatever might be going on over there, and that male history. And it's that male history that's just not really happening as well as it should do.
Yeah.
I think when we first met only a few weeks ago, but I'm not going to say we met in a pub. We didn't meet in a pub, but we went to the pub afterwards. But it's like, oh my God, it's like totally aligned in what we were talking about. But it's about that comprehensive assessment and history of both of them together. And I think what we see all the time is it happens too late for the man. That, it's right, off you go, case in point, Toby, go and do your 2 rounds of IVF, or 3 rounds, or now only 1 on the NHS. Go and do all of that. Let's see if that works. And then we might look at the man. Or, God forbid, like, okay, all right, well, yeah, okay, you've had 3 miscarriages now. Now we'll look at the man in a bit more detail.
Yeah, let's see the DNA fragmentation. Let's do your karyotype. Yeah.
Yeah, it's just absolutely, it just doesn't make sense.
No, and what about all the couples out there that, they've had a child with a previous relationship and now with a new partner, whichever way the child is on, but then they don't get access to NHS funding anyway at that point. And so, but they think that they need IVF because they've struggled with conception, but actually for a relatively small cost, or quite a simple process to follow with examinations, they could then uncover an issue that then could be rectified without even the need of it. But it seems that that's the trend, isn't it? The trend is that you kind of just shoehorned into this kind of process that's what you need if you've struggled.
Yeah.
So.
Well, Jonathan Ramsey sort of said on this podcast, like, ICSI kind of killed andrology in some ways. Like, we'll just rely on ICSI.
I wouldn't say. I mean, we have to realize that ICSI revolutionized the management of infertile It's not that. It's about trend. Okay, so. Oh, now we have ICSI, so nothing else matters because ICSI bypasses all the barriers? The answer is no, it doesn't. Okay, and that's why, if that is true, the success rate is going to be 100%, and it's not. So, but no, IVF treatment and ICSI, they revolutionized the world of fertility, especially for azoospermic
absolutely.
men.
Then,
Okay. Because before that, let's say if someone was azoospermic, even if it's a blockage, and we know a blockage that is not reconstructible, like if the blockage is intratesticular, and we know that the testes are full of sperm, there was nothing that you could do before ICSI.
Yeah.
So I wouldn't look at it as it killed, but what it's led to is that and I'm not talking, put the azoospermic men aside. So what's happened since the development of IVF and ICSI and so on is, as long as the fertility world became mainly dominated by the gynecologists and IVF units, and so as long as the male has motile sperm in the ejaculate sufficient for the ICSI cycle to happen, the male doesn't get referred. Okay, so this is what it's done.
Yeah.
Okay, whereas before that, all men used to see because there was nothing else to be done. So, so this is what it's done. And this is what we are trying to
undo in some ways.
undo.
Yeah.
So just because we have ICSI, that doesn't mean, hormonal treatment is not going to work. Doing a varicocele is not going to work. No, this is a wrong concept.
Yeah.
So I think it's the trends. So I think ICSI is a huge plus, but that does not mean that we forget all the other things that we can do to help the infertile man. This is what I mean about it's teamwork. We have so many diagnostic tools. We have many treatment tools, many treatment interventions. We should utilize all those technologies and all those treatments to help the couple achieve pregnancy. Okay, not just say, it's just going to be this. It's just going to be that. So for me, it's an amazing line of therapy, but it should not be looked at as the only line of therapy.
Yeah,
amen to that.
Yeah, absolutely. Absolutely, man after our own heart.
Yeah.
We've mentioned hormones a couple of times, and this is something I wanted to pick your brains on because we're working together already. You're referring some of your patients through to our clinical services. So I see those referrals and it's like, it's this blood test, it's that blood test. And it's like, oh my goodness me. But actually it's something we've not really discussed on here much is male hormones. And I do it when I go and give talks or if I'm on a webinar or presenting somewhere. It's like, I always say we have the same hormones as women. We have follicle stimulating hormone.
Yes.
We have luteinizing hormone, which women get checked for with their GP. They have testosterone. We have testosterone. We rely really, it's fundamental.
We
right?
have estrogen as well.
We have estrogen, yeah, of course. Hormones are absolutely fundamental to spermatogenesis, to our testicular function, but they don't get checked routinely for men, do they?
Yeah, but as a rule of thumb, any man under 10 million, with a count under 10 million per ml, you should have your FSH, LH, total testosterone, prolactin checked, plus minus estradiol or estrogen, especially in overweight men.
Yep.
Okay, so this is so if the count is under 10 million, this is mandatory. Okay, of course, that does not mean that we're not going to do it if you're under 15, but 10 million is the cutoff where it should be done.
Right.
Okay. So this is for many reasons. In many cases, it can help us identify the problem, whether it's a secondary hypogonadism, like the problems in the pituitary gland, not producing enough FSH, LH, or some of the patients may have hyperprolactinemia secondary to pituitary adenoma, which is mostly a benign tumor that can be treated medically. Or it will help us identify primary testicular failure. And also, in my practice, sometimes I give empirical hormonal stimulation, for the infertile men. Of course, you can't give testosterone because testosterone will suppress the fertility. And I'm sure most of the people know that by now, that when you take exogenous testosterone,
would think, wouldn't you?
you are literally shrinking your testes. Because if you take exogenous like testosterone from the outside, what that does, it tells your brain, the pituitary gland, that the testes, it doesn't realize the difference, that the testes are doing a fantastic job because there's a feedback mechanism between the testes and the pituitary gland. So if someone takes this testosterone from the outside, you're telling your pituitary gland, testes are doing an amazing job. We've got good levels of testosterone. So what happens? The pituitary gland shuts down FSH and LH production. So they drop. So that means the production of testosterone in the testes drops.
Yep.
Now, for sperm, you're going to tell me, well, the total testosterone is normal. But for spermatogenesis to happen, you need much higher concentration of intratesticular testosterone. So if there's no production of testosterone within the testes, spermatogenesis stops, even if the blood levels of testosterone are normal.
Right.
Okay, so this is why it's happening. So you need testosterone in the testes being produced by the Leydig cells within the testes for spermatogenesis to occur. And this is why if you take testosterone from the outside, you're shutting down spermatogenesis, testicular production. Sertoli cells need FSH. You're also shutting the FSH. So no. So hormonal therapy for subfertile men, you either give something like SERMs, which is selective estrogen, something like Clomid or tamoxifen, and these will make the brain blind to the level of testosterone, and therefore the brain is going to produce more FSH and LH, which stimulate the testes to work harder. Something like Clomid.
Because a lot of men get confused by that because their partner might be on Clomid.
Yes,
she's got PCOS.
Yes, it's off-label use. Off-label use. So the hormones are the same. Okay, but the end product is different. So in women, FSH, LH, the end product is estrogen mainly and ovaries. In man, FSH, LH, the end product is testosterone from Leydig cells and sperm, orchestrated by the Sertoli cells. So the end product is the same. The other thing that you can give is HCG, human chorionic gonadotropin, which acts like LH, and also women take that to induce ovulation. Okay, so it's the same products, but they are used differently.
It does seem crazy to a layman though that's like, hang on, my wife takes this.
Also, when you eat, it's licensed to treat female breast cancer, female and ovulation. So that makes it. So I always warn patients. By the way, you're going to read this. The pharmacist may quiz you. Just tell them. Don't worry. So of course, if the hormones are normal, and then we are giving this empirically meaning that I'm trying to superstimulate the testes. So this is empirical. But if the FSH and LH are low, in that case, hormonal treatment is not empirical. It's going to cure the condition. As in men with hypogonadotropic hypogonadism. So if you see a patient, azospermic, so if you see a patient, azospermia, that means no sperm in the ejaculate, you do a hormonal profile, you've got low FSH, low LH, low testosterone, you don't do a surgical sperm retrieval.
Because the testicles aren't working.
Exactly. And I've seen patients who've had surgical sperm retrieval when in reality they have low FSH, low LH, low testosterone. So this means, this is secondary hypogonadism. It means that your pituitary gland is not producing FSH and LH, and therefore the testes are sleeping.
So it's secondary to what's going on in the pituitary. That's why it's called secondary.
And sometimes it's idiopathic, like there's no, and this is the most common cause, by the way, so there's no particular cause. So it's genetically determined, where the pituitary gland is not producing enough FSH and LH. It can be secondary to head trauma, radiotherapy, brain tumors, and so on. But the most common cause is idiopathic. Idiopathic is usually meaning it's a genetically determined condition where the pituitary gland is not producing enough FSH, enough LH, and therefore the testes are not producing testosterone and sperm. So the management here is 100% medical, hormonal. You give the missing hormones, mainly the LH in the form of HCG, the human chorionic gonadotropin, and then later FSH. Okay.
I hope everyone's listening at home, because there's going to be a quiz at the end of this episode.
It's a lot to take in, but actually, when you break it down like that,
in simple terms,
it is a fact. There's a kind of a factory system kicking on, isn't there? But one thing I want to just rewind a little bit about kind of receiving testosterone from an external source is, and gym buddies and young men need to listen up on this, because there are a lot of youth that take testosterone now for making themselves look hench and be better in the gym, but they don't realize actually what they're doing is they're really, really impacting their potential fertility health for the sake of a few kilos of muscle, whatever they want to look better. But this is a really important topic because you're effectively switching off that factory if you take testosterone replacement therapy.
And it can be permanent, right?
It can be. I mean, it can be reversed, but 10% it's permanent because the lack of FSH and LH permanently shuts down the testes. But majority of cases can be reversed by stopping and giving the right hormones, mainly HCG. But in 10% of cases, it's not reversible.
Yeah.
Because the shutdown of the FSH and LH permanently shuts down the testes, maybe less than 10%.
That's scary, though.
It's quite
isn't
scary.
It? It's like, that you'd like, let's say, down the gym, Gary, as Anand called him, has sold you something he's found on the internet, and you kind of, guys don't know this, like it's, in some ways it's quite simple to understand. Signal from here, down there, makes it all work. You get another signal going back saying, okay, brakes, ease off, accelerate it. That's all that's going on, isn't it? So it's quite, I kind of simplify it in that way because that's how I work to make it sense for other people. But we don't get taught this. No guy out there, you can pick a guy off the street that hasn't been through fertility, even the ones that have been through fertility, they can have no idea about how their hormones work. To be fair, when I was an acupuncturist and mainly treating women, the number of women I had to educate about their menstrual cycle and tell them, like, this is how and when you ovulate and these are the signs, and, second half cycle should be 14 days and all this, that, and the other. And like, I had no idea, and they're 38 years old. It's
and
mental.
that's why the testes shrink as well. If men are just taking testosterone without HCG, the testes shrink in size for the same reason.
Wow. Nobody wants little balls.
No. Yeah. So if you just for the reciprocal of that, so if there was a hormone issue with a guy and you managed to treat it to get the factory kind of working again, would they then see an increase in size of their testes?
Yes.
That's interesting.
Yeah.
Okay.
And basically, kind of the size of your testes really does determine your sperm volume, right? And concentration to some degree.
In count.
Right.
Yeah.
Count.
The count. Yes, that's true. So we have these if the testes are less than 3 centimeters, or 3 centimeters or less, that is usually associated with very low sperm count or azoospermia. 5 centimeters and more. But again, this is not absolute. So you can have, this is not an absolute guide. Again, that's why it doesn't have to be, it doesn't have, you can be azoospermic and it's not obstructive azoospermia with normal testicular size and normal hormones.
Oh, right. Okay.
So just having normal testicular size and normal hormones, so nothing has to tick all the boxes. That's why when you're diagnosing, again, it's history, symptoms, signs, labs, and so on. And sometimes you still don't have a 100% diagnosis. But usually, small testicular size is associated with a very low sperm count or non-obstructive azoospermia, and vice versa. But this is not absolute.
No.
Yeah.
Interesting. I mean, I'm wondering how many guys right now are just having a little feel just to
got their ruler out.
Yeah, just to double check. But that's a really important point to make, isn't it? And that's why what we're saying here is that it's about a full picture of the man rather than just one individual thing. And why we kind of always drum about the semen analysis is just that's one thing of many things.
Oh, good, yeah.
And why is it relied upon as the gold standard when actually we need to look at the whole picture here? I think that's really the message in this podcast today, isn't it?
But that it is so nuanced and so personal. And I think this is the way health is going, actually, isn't it now? Is I think we're recognising the need for personalised medicine. That, one guy's low sperm count will be completely different to another guy's low sperm count. Obesity or diabetes will be driven by different things for different people, and you've got to understand that person as a whole. And we're just not doing that for guys, really, are we, at the moment?
Exactly.
And then the long-term implications for that as well, for men's health. One of the other subjects we talked about off-camera, which we haven't done on here yet, is ED.
Okay.
Well, erectile dysfunction, for those that are like, what's ED? And actually, this ties in with hormones as well, really, doesn't it, to some degree? But there are many other issues. I mean, how do we unpack this one? Where do we start?
Okay, so in a nutshell,
Excuse the pun.
That's the first one of the day.
Yes.
so I mean, ED is a very big topic, so I'm going to try to make it as simple as possible. So we look at ED. What most people don't realize is that age is the number one risk factor for ED. It's not diabetes, it's not hypertension, it's not, of course. So if you're diabetic, if you're hypertensive, if you're obese, if you smoke, if you eat unhealthy, that accelerates the onset of ED. So if genetically you were going to develop ED by the age of 60, you're going to develop it by the age of 40.
If you haven't got the right lifestyle.
If you don't have the right lifestyle. And we look at ED as a marker of cardiovascular disease and so on. But age is the number one risk factor. So statistically, around the age of 40, 30% of men will have ED. Above the age of 50, half of the men will have ED. And this is regardless of lifestyle factors or other disease. We call it comorbidity. Comorbidity is other diseases, like if someone's diabetic, hypertensive, and so on. So independent of those risk factors, these are the stats. Okay, so it's more common than what people think. And of course, sometimes people like to think black or white. That means it's either working or not working. But there are different shades of grey. So there's mild ED, there's moderate ED, there's severe ED, and so on. So
the halfway up or
these
halfway
are
down.
These
like
are the
Humpty
stats.
Dumpty.
Yeah, it doesn't. The first sign is the reduction in the quality and frequency of nighttime morning erections. This is the first thing. So if you're 40 and you've noticed that your nighttime morning erections are not as frequent as they used to before, that's a sign of an aging penis. Okay, so you address it. The most important thing, of course, rule out any underlying risk factors. And this is your routine checkup that you could do with your GP. And we like to include the hormones because most GPs, when they do a routine checkup, they're going to check your lipids, your glycosylated hemoglobin, your blood pressure, but they won't really put huge emphasis on your testosterone. So this is important to add. So once you've ruled out any underlying risk factors, then it's up to management, and we have different tiers of management, whether medical, interventional, or surgical, of course, like the penile implants, which you are interested in.
Which I'm interested in. That's got all sorts of strange connotations.
Yeah, Ian's booked it for surgery. But it's an interesting topic, isn't it? Because there's a lot of stigma around kind of ED, and you know, the fact, the stats you just mentioned there, how many people are affected by this, it's very, very common. And yet, actually, among peer groups in men, it's a conversation like no one.
Men generally don't. No, men suffer in silence. I always used to. They just are not very vocal about their problems, and this is what patients I see for Peyronie's disease, which is scarring of the penis. This is something that affects up to 9% of men.
Wow,
it's very common. So that causes significant penile curvature due to fibrosis. So it affects, according to the studies, 3 to 9% of men, and these numbers are very high. Yet you would never be talking to your friend and discuss that with him, because men are very they don't discuss these.
Yeah, which was actually
things.
a question I had in my mind then, is okay, so yeah, there's the stats in terms of ED as men get older, which is quite interesting when you said a third. I'm thinking, okay, it was me, Mike and Toby sat around this table, but you're still under 40, so...
I'm all right in a minute. Yeah.
But it's like, okay, so you say, okay, at 40, you know, some of the signs might be you're getting less frequent nighttime erections, your morning erection might not be as firm. But what is normal? You know, and that again is going to be this personalised medicine sort of approach, isn't it? But again, it's like, we talk about anything and everything between us all, but me and Toby don't sit and chat about how's your erection this morning.
But we don't.
I thought you were going to ask. I thought you were going to answer that. You're up early.
But we don't, though, do we?
No,
you know, we don't.
So you don't therefore have a benchmark of what's normal.
Yeah.
So it's therefore very easy for it just to become this kind of silent thing that's happening to your health that you haven't got that benchmark. You're not talking about it. but it is a proxy for your cardiovascular and metabolic health, and it just goes unnoticed.
Exactly.
Yeah, but similarly in the fertility space, when a man realizes that they're infertile or subfertile, the first thing they question is their masculinity. Yet we know they're still a man and they're operating as a guy, and all good. And ED is, I guess, in that same bracket, right? If you've got a form of or a level of ED or erectile dysfunction, then is the question: does it question your masculinity? And it really shouldn't, because of those reasons. That actually there are ways to treat whatever condition might be present, but also looking at your future health as a biomarker. I think like the sooner you get these things sorted out, the better you can move on with a healthier outcome, and then get back what you kind of lost, if that makes sense. But it should never be a question of your masculinity. And why don't we talk about it? But it's true, though, isn't it? We don't sit and talk about.
We'll talk off camera about our erections, mate.
There's one for Instagram Live.
It's a psychological. I mean, it's a mindset, but I think it's changing slowly, because I think with social media and also ChatGPT, I mean, there's a huge awareness of different men's health topics, and I see many patients who actually self-diagnose with conditions like Peyronie's disease. They diagnose it before their GP, and they come seeking help because
they've been on the internet.
They've been on the I mean, there's more awareness now compared to like 20 years ago.
Yeah,
you didn't talk about this stuff 20 years ago, did you?
There's a huge awareness now. So for a condition like Peyronie's disease, for example, it was very rare to see a patient in the acute phase. The acute phase is the first 6 months of the scarring process. By the time the patient goes to see their GP and their GP diagnoses and then refers them to see a specialist, we used to see patients after a year and a half.
So it's a lot harder to treat then.
Exactly. But now I see patients within the first few months, sometimes few weeks.
Which is really
good. They go on ChatGPT, self-diagnose, they refer themselves, and then you start and of course when you treat it within the very early onset, the treatment is much easier.
I didn't know Peyronie's had like an onset like that. I almost thought you were kind of born with it.
No, that's called congenital curvature. That's a different type.
Right.
So congenital curvature is one side of the penis outgrew the other.
Right.
So this is a structural problem. It's not due to real scarring. And this manifests with the onset of puberty. And most men, they would have some degree of a congenital curvature. As long as the angle is under 30 degrees, then it's fine. You leave it.
So now they've got the protractor out. They've got to have the ruler out for the testicles.
There's an app actually. Is there? Oh yeah, there's an app. So if you go my Peyronie's disease, something like so, that you'll find lots of apps. So of course, if it's ventral, that means it's pointing down. A 30-degree ventral may be problematic, but if it's like a 30-degree to the left or slightly under, we can tell the patient most probably that's not going to get in the way. But this is congenital curvature, so one side outgrew the other. Okay, but Peyronie's disease is a scarring condition, most commonly in the 4th, 5th decades. Usually, trauma to the penis, trauma during erection in someone who's genetically predisposed.
Oh, right. Okay.
And then that trauma induces injury. The injury induces a scarring process. The scarring process causes shortening of the affected side, and therefore that causes the curvature.
Right.
Okay.
So love it. Excellent. I love learning.
And that causes curvature. So
So it's specifically trauma when you've got an erection that will trigger that.
That's the most common cause, yeah.
So this reminds me of a conversation we had at Eshrei with a couple of our other consultant friends. So this might well be over vigorous sex.
Yes.
And
it depends on the position.
Reverse cowgirl here.
It was reverse cowgirl.
That is very, and of course sometimes if the trauma is that severe, actually you get what is known as a fracture penis.
Oh no.
So fracture penis, they call it fracture because you hear a snap sound. and there's bleeding inside hematoma.
Yeah,
The
yeah.
penis is like an aubergine. This is an A&E. This is a difference. So patients present with, and there's immediate. So fracture of penis is that trauma, but severe. Patients hear a snap sound, immediate loss of erections, pain, and the penis is like an aubergine. This you go to A&E because it needs to be surgically repaired. So that's fracture of penis when the trauma is severe. It's like the penis bursts from the there's a tear in the tunica albuginea, which is the layer that surrounds the erectile tissue. So this is a severe trauma. The less severe trauma may cause Peyronie's disease in someone who's genetically predisposed, whereas just a minor injury that heals with an exaggerated scarring, causing shortening of the affected side and the curvature. And even less severe repetitive trauma will lead to erectile dysfunction.
Right.
Because you're damaging the erectile tissue, repetitive trauma, and sometimes that happens. Repetitive masturbation or rough masturbation, the same thing. So minor repetitive trauma can lead to erectile dysfunction. Peyronie's disease, in the severe form of the trauma, it can it can lead to a fractured penis, which is an A&E thing.
It's fascinating, isn't it?
It is fascinating,
I'm
but-
sure anyone eating their dinners now has definitely stopped.
Definitely gone off
but
the
but it's really
quite
fascinating because these are things that we haven't spoke about before on our podcast, and someone listening to this might fall into that bracket that actually that could well be me, and maybe I need to get checked out, and there is treatment options. So it's really good awareness.
The nice thing about Peyronie's disease also that back in 2010,
Nice thing. What's
the only nice thing,
Oh.
back in 2010, the only treatment was surgical.
Right.
So surgery, okay? But right now, we have a number of products that can be used, especially in the acute phase, and whether oral or injections, and they can help reduce the scarring
Wow.
of the penis. So that's not, I mean...
And then to avoid surgery.
And then avoid surgery, because of course surgery is not the best
Always comes with
option.
potential complications. Yeah.
In that case, yes.
Because what are you doing with surgery? You kind of just trying to break up
Well,
that, cut out that
two
tissue
types of surgery. The standard, when the curvature is under 60, you shorten the healthy side to be as short as the diseased side.
Oh, crikey.
So this is called plication surgery. Okay. The other type of surgery is called incision and grafting, where you open. So, of course, the plication surgery, one of the problems of Peyronie's disease is the curvature, but actually most men would have lost length. So if you're going to tell them I'm going to do a surgery to shorten the penis, they will not going to be they won't be very happy. The other surgery is called incision and grafting, where you open the scar tissue, and then because it's under tension, it's going to spring open, but then you're going to have a defect. You're going to need to patch that defect with a graft. This is called incision and grafting, or Lou procedure. But the problem with this procedure is that it's associated with very high levels of erectile dysfunction, like 20%. For the incision and grafting. So nothing ticks all the boxes.
It's not much of a choice, is it? You can have a smaller penis, or you can have one that's same size as it is, but you might not be able to get it up.
Exactly. So, but over the past 10 years, there's been huge advances in the non-surgical treatment for Peyronie's disease. Statistically now, I only operate on 15% of my patients. 85% I don't need to operate because the non-surgical methods work, whether it's especially when patients present in the acute phase.
And like I say earlier, like the earlier you get checked out,
The earlier the better.
and hence why removing the stigma of this kind of thing is really important, because if you suffer in silence for too long, then you are potentially at then more risk of not having a better outcome than had you come earlier, right? So
Yeah, it's much easier to treat the scar tissue earlier as opposed to later. Yeah.
Crikey, I mean, like the breadth that we've covered just here is phenomenal. But like, this is the breadth of your clinical practice, right? You're
Not
seeing,
all of it. Yes, this is only a pot.
What else? Are we
Yeah, there
missing?
are other. No, there are many other conditions that we can cover, like buried penis, people with buried penis, men who've been over circumcised, men with penile size issues. This is another aspect that we
And
address
how
as
much
well.
of this sort of stuff, so everything we've covered today and more that we could probably cover another day, how much of this interplays with infertility? Because, infertility on its own.
That's a good question. That's a very good question. Okay, I'll tell you. Okay, someone with erectile dysfunction, severe erectile dysfunction, will be infertile indirectly, mechanical infertility.
Yeah.
Okay? Someone with severe congenital curvature or severe Peyronie's disease also will be infertile, but this is mechanical because sperm is not you can't either you can't have a hard erection for coitus penetrative intercourse, or the curvature prevents proper sperm deposition. So that's related. So that's penile curvature. Patients with buried penis, again, the same thing. They won't have enough size to sort of patients with ejaculation problems. So some patients can't ejaculate during intercourse.
Right.
In a way that can lead. Of course, these
Is
are
that
easily
a psychological thing, or is that a
different. Can be
physiological thing?
psychological, can be like anything. It's multifactorial. Sometimes psychological, sometimes it's just the way the reflex is, and sometimes, of course, due to medication, sometimes due to surgeries, or due to neurological disorders or hormonal problems. Like any health condition, you can have or some men with premature ejaculation actually ejaculate before penetration. So again, this is an indirect way of infertility. So all these things are interrelated, are in the mix. So in a way, it's all sort of related.
All connected.
Yeah.
I mean, we've nearly done an hour already, and it feels like it's gone like that. But kind of, what's it? So we will wrap up soon. But so when a guy comes to see you, like for his first appointment, right? He's kind of taken that step. He's a bit nervous. Been trying to conceive for a year and a half. Maybe had a cycle of IVF. It hasn't worked. Seemingly, he's told everything's okay because he's had a semen analysis and it's within normalish range. What's going to happen? What's your kind of mental checklist or even a physical checklist? What are you going to go through to make sure you've covered as much as possible?
So, of course, I'm going to go through the history. Anything in the history that may affect the quality of the semen, like history of sexually transmitted disease, infection, pain with ejaculation. Do you smoke? Do you don't smoke? Your dietary habits, your lifestyle. Do you do sauna, jacuzzi? All these things. History of other illnesses. What medications are you taking? So you can be on a medicine that suppresses fertility and so on. So history. What surgeries have you had before? And then I will take full sexual history to make sure we've just discussed how erections and ejaculation and the size position of the penis may have an impact on fertility. And then I'm going to examine the scrotum for any nodules, lumps, bumps. I'm going to check the vas if it's present, if it's got nodules. I mean, you can have reasonable semen count, but one vas is absent, for example. This is called unilateral vasal aplasia, so it doesn't have to be both. So you're going to check the vas for the present. You're going to check the epididymis for any nodules, denoting that there's been previous infection/inflammation. And very important in that context, I will check clinically for varicocele, which is a very important risk factor or cofactor for subfertility, even with normal semen parameters, because sometimes the effect of the varicocele is on the DNA fragmentation.
That was me.
Okay, so and DNA fragmentation, you're not going to pick it up in the normal semen analysis. It's a special test. So I'm going to look for varicocele testing. So that is very important. Of course, when I see a patient with varicocele, this is something many people miss. You really diagnose it with the patient standing, even if you're doing an ultrasound, because it's like a hernia. Some people examine for it when the patient is lying down. I don't know how, especially ultrasonographers, so they do it with the patient lying down. But this is like a hernia, so you need to diagnose it with the patient standing. I will request, if the semen is already done, I'm going to request a semen culture. Okay. And sometimes, not all cases, I do express prostatic secretion to look for chronic infection, but this is based on clinical suspicion, if the semen has white blood cells or, but then when it comes to what test for me, the most important thing to check for, I would check the hormones, but I would check for DNA fragmentation and possibly oxidative stress. For that patient, because for me that may be the cause of why the IVF failed, is high sperm DNA fragmentation, which is and I see that a lot in my practice. Patients with failed IVF cycles because of high DNA fragmentation.
And then it's finding out what is the cause of that DNA
and it's not
fragmentation.
uncommon, like Toby, for me to see a patient sometimes referred by a colleague, repeated failed IVF cycles, and please check if he has a varicocele. And we do the varicocele with the aim of helping the IVF cycle succeed, but the patients actually conceive naturally. Okay, so and this is exactly like the scenario that you mentioned. But I think this is what gave varicocele or varicocele treatment maybe a negative, because I think back in the days before we had ICSI, before it was overdiagnosed, overdone.
Oh, really?
Yes.
Oh, okay.
Interesting.
Yeah, because it was one of the few things
That you could
that
do
we
to
could do
to
to help patients back then. So there was overdiagnosis, overtreatment.
That would explain a lot.
That does explain it, because obviously there's so much. Well, there's been so much discussion about the research.
Yeah.
And maybe that's one of the big things, and is it overdiagnosed, overtreated, and that's
the
skewed
older
the data.
the older data is skewed. I mean, they were treating even subclinical varicoceles. I don't treat subclinical
Which
varicoceles.
is probably not going to have any
It's
impact
not going to have any impact.
outcome.
I don't even treat grade 1 varicocele, unless it's maybe someone with a left grade 3, right grade 1, fine, I'm there. I'm doing microsurgical subinguinal varicocelectomy, so I'm going to do the left and quickly do the right. But, so I think there was overdiagnosis, overtreatment. But when the varicocele is prominent clinical varicocele that any doctor agrees, yes, this is a varicocele, and you treat it, that will have a significant impact on natural conception and on even success of assisted reproduction, even in the presence of normal semen parameters, because you've got the sperm DNA fragmentation.
Yeah, absolutely. And we're now seeing that change with the new NICE guidelines coming out. They should be coming out April 2026, so this will probably be out by then. But they're now recommending, they're only recommending for suboptimal semen analysis and a varicocele present that you treat it. There's no mention of DNA frag. Let's take the wins that we can get.
Most of the experts agree that when the DNA fragmentation is high, you've got a clinical varicocele, it's warranted to treat. Yes, but sometimes you have to realize that it takes time for guidelines to change.
Okay. Well, it's taken bloody 20 years.
Because, varicocele wasn't recommended for fertility treatment in the first place. This changed in 2023, the guidelines that you are referring to. Before that, the NICE guidelines were varicocele should not be offered to treat male infertility, and it should be offered to treat pain. And that's what many of the specialists were doing.
Yes, that's what many of the patients are suffering with.
You have pain, sir. Yes, it hurts you. Yes, But now, thankfully, the guidelines have changed, and I think, but we're ready. Yes, so that is something very positive.
But I think just going back to that consultation, like what you've said, you cover. Because there's always this thing in fertility treatment, isn't there, of the cost. The cost, mainly because the big cost is the IVF or the ICSI, £5,000, £8,000, £10,000. And so the thought of going to see another consultant that's going to be another couple £100 and then maybe quite a few more £100 for tests on top of that is kind of, I think it's quite hard for couples to get their head around that investment or that expense. They maybe don't see it as an investment, but actually, with everything we've covered today, hormonal function, testicular function, long-term health, going to see a specialist in urology and, in this case, andrology and male fertility, it's not just about your sperm. This is about your hormonal function. It's about your metabolic health. It's about your cardiovascular health. It's about everything. So, who wouldn't say, well, actually, I'm going to invest 250 quid to get a really good male health check, although it's about your fertility, it's really a male health check, that is going to stand me in good stead for the rest of my life. It's not just about this bit now. And I don't think people have quite got that mentality yet, because it's not really been put across to them as something of huge value.
Yeah.
So I think we really need to change that narrative.
Yeah, and I think it's slowly changing, especially with all the men's health groups. And I mean, I think there's a huge awareness now compared to 5 years ago or even 10 years ago about the topic of men's health in general. So if you look at men's health as a topic, it was always under the...
It's like a taboo.
Yeah, it is.
It was always... And it was...
Well, we've only just got our first men's health strategy last year. You know?
It was always under-addressed by most health systems, be it private or public health systems across the world. But I think now men are becoming more aware of men's health issues, like any, it's not a taboo. Like you said, previously, men's health was a taboo or something mystic or something spiritual, something related to your manhood or whatever. But all men's health issues are like any other medical disorder. Okay. Yeah. So it's the same way you manage any other medical disorder. And I think, thankfully now, compared to 5 years ago or even 10 years ago, there's a huge awareness amongst men and of the different men's health problems. I see different groups of patients. There are many forums that patients form, and online forums for something like Peyronie's disease, for penile implants, for hormonal problems, and I think this is all is going to be very positive for the speciality of men's health in general, and for even it's a positive feedback loop, the way I see it. So there's going to be awareness, there's going to be demand, more doctors are going to be interested, more doctors are going to be subspecialized, and so on. And now we have societies amongst doctors. Of course, there's the British Society of Sexual Medicine, which is an affiliate of the European Society, which is an affiliate of the International Society. We also have the British Fertility Society. So, I think
it's going to grow.
It's going to grow. Yeah. It's
exciting times, isn't it? I think hopefully for men's health.
Exactly.
In for some good days for us guys. Finally. Finally.
Look, brilliant. Amir, it's been absolutely fantastic chatting. I kind of don't want to pull this conversation to a close, but we've done over an hour. So I think you're going to have to come back.
Thank you. I would love to.
You're going to have to do another one. Let's kind of wrap up with, where do people find you? Where do they come and find you for this fantastic consultation?
That people can find me at the Male Factor Fertility London. So it's the Male Factor Fertility London. So this is a platform that I have launched specifically to help men with subfertility, where we can do online consultations or face-to-face consultations depending on the case. And it's designed to be available and cost-effective. So,
brilliant. Well, we'll put all those details in the show notes. So a link to your website, and you're on Instagram as well.
Yes.
You started off on the Instagram, haven't you?
Yes.
So we'll put all of that on there. But thank you. Thanks for coming in today. And thanks for the work that you do and like the passion that you've got to make a difference, because you're making shit happen. You're making stuff happen, But that's in our little sphere as well, in terms of what we're doing in the male fertility space. You're working with us a little bit at Fitzrovia Hospital as well, and done some great stuff there. But thank you. Me and Toby are now going to go off and talk about our erections, aren't we?
We'll chat about that after the show.
Yeah, but don't worry, any erection problem 100% fixable.
Excellent.
Good to hear. Well, thank you so much.
And not necessarily having to have a penile implant. Okay?
Yeah.
So we can fix it
which I have no interest in terms of personal issues. But
And it's safe to say at the end of this podcast, you can resume eating your dinner now. So enjoy.
Thank you, guys. It's been a great pleasure to be with you. And yes, I look forward to visiting you again.
Yeah, brilliant. Awesome. Cheers, Emma. Take care, everyone.
Thank you.
Bye-bye.
Bye.